Picture this. A physician handwrites an order for 6 units of regular insulin, but instead of writing out units, he just abbreviates and uses the letter U. When the nurse takes a look at it, it really does look like a 60. She's had a busy day, she's got a million things on the go, and she proceeds to administer 60 units, 10 times the ordered dose. Scenarios like this, unfortunately, can happen in paper-based systems, which is why health systems around the world have been diligently working to implement closed-loop medication management. In this video, we're going to take a look at what the key components of closed-loop med management are. But before we dive in, if you're new here, my name is Trey. I'm a healthcare IT consultant and founder of the Dragon Network. Okay, let's get started with the first step of closed-loop med management, which is CPOE. CPOE stands for Computerized Provider Order Entry. It is when providers enter the order directly into an electronic system instead of handwriting it on paper. It removes the need for transcription and removes some of the errors that are caused by handwriting or miscommunication. Each order outlines the medication, the dose, the route, the frequency, and the duration. CPOE systems also have access to drug databases, allergies, lab values, previously administered medications, and other key important information from the patient's chart so that they can provide real-time clinical decision support to the ordering provider. As a health IT professional, how you set up CPOE directly matters for patient safety. Every alert threshold that you set, every drug database update that you deploy, and every clinical decision support rule that you maintain affects whether dangerous drugs get caught or slip through the cracks. Once we have the order entered into the system, the next step in the closed-loop med management is pharmacy verification. The order is transmitted to the pharmacy module or system where it is reviewed for safety, dosing, and potential interactions. This is a step to confirm that what was entered is appropriate before it reaches the patient. It also confirms the timing, so that medications can be dispensed to the appropriate locations at the appropriate times. Some organizations will also integrate the pharmacy verification process with their medication dispensing cabinets. This is to add an extra layer of safety checks so that when someone goes to take a medication out of that particular cabinet, it double checks against the order that was verified to make sure that what they're removing is in fact the drug that they're intending to remove, that the dose is the right size, and that the timing is correct. So once we get through the pharmacy verification and the dispensing, the next step in closed-loop med management is eMAR, or the Electronic Medication Administration Record. This takes the verified orders from CPOE and presents them in a time-based, patient-specific format that supports safe medication prep and administration. It enforces the timing, tracks administration histories, and provides additional safety checks like weight-based dose calculations. eMAR is not just a digital med list. It's an active workflow management tool. And when health IT professionals can optimize eMAR displays, alert timings, and integration points, they're directly supporting nursing workflow efficiency and safety. Unfortunately, poor eMAR configuration can create workflow barriers, and this often sets the situation up where nurses are forced to create workarounds, and there's an increased risk of closed-loop med management not working. The final step in the process is barcode med administration, or BCMA. This requires nurses scan the patient identification and the medication barcodes for positive identification and last-minute safety checks. BCMA enforces the 5 rights of med safety: right patient, right medication, right dose, right frequency, at the right time. If any of the 5 things don't align with the CPOE order that was verified and is now displaying on the eMAR, the system will pop up an alert as a final check to prevent errors at the moment of administration. One key thing to keep in mind is BCMA technology actually relies quite heavily on device integration with the EHR and on the IT infrastructure. So in order for it to be successfully used in workflow, you need to make sure everything is connected, information is flowing back and forth, and you don't have any lag. Because the last thing we want is for real-time checks not to be happening in real time. So let's do a quick recap. We start with CPOE, where instead of writing the order down on paper, the provider enters it directly into the electronic health record, or CPOE ordering system. This cuts out the transcription errors and allows clinical decision support to be integrated right into the workflow. Next, the order moves over to the pharmacy, where it is reviewed for safety, dosing, and interactions. If everything looks good, the pharmacist will verify the order, which then has it land on the eMAR. This creates a clear schedule for nursing staff and shows what's been ordered, when it's due, and in the context of what's already been given. At the bedside, BCMA is the final safeguard. Nurses scan the patient's wristband and the medication barcode to confirm the 5 rights. If something doesn't match, the system won't allow you to proceed. BCMA then updates the eMAR and allows for the information to be leveraged in clinical decision support when future orders are entered. So for health IT professionals, it's also important if you are making changes to any component of the workflow that when you go through things like user acceptance testing or integrated testing, you actually include the end-to-end process and don't just focus on the one component that you've changed, because closed loop med management really needs to have all those 4 pieces together. So I hope this helps you understand a little bit more about what closed loop med management is and that you have a great rest of your day. I'll see you again next time.